Well, buenos dias and good morning, good afternoon, good evening. My name is Jody Scholes. I'm your instructor for the MBLEx review course. And in this course, today we're going to be covering three different things. I love to cover three different parts of this course of class. And the first part is almost always about the actual test. I'm going to give you some hints on the actual test. Second part is we learn. We go through the material. We go through the actual course material. Today, we're going to be talking about pathology. Love pathology. And then once we're through with the content, the actual learning part, then we're going to go dissect some questions. And so if you're here to dissect questions, if you're watching this recording, the last about 10 to 15 minutes of class will be dissecting questions, which you can go over and over and over again. But today, I want to talk to you about what is the MBLEx. It is a computer adapted test. And if you may have heard me talk about it before in the links, well, actually, you can go find it yourself. But a computer adaptive test means that it gets a little harder when you get an answer right. So that test adapts to your test taking. The goal of the MBLEx is to score 630 points. And years ago, we used to get a score, but now we don't. We just get a pass or a fail. So we don't actually know what areas we need to study more of. However, I have a practice exam. If you haven't been taking practice exams, if you don't know what areas that you need to polish up, then feel free to reach out to me. I'll definitely put my email in the description here, and just reach out and we'll do a practice exam and just see where are you scoring high, where are you scoring low. And most times it's just a matter of doing something called building your test taking stamina. And I really want to drive this home. We've had students who just take practice exams, blah, 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 all the time, and they don't pass. Practice exams are not enough. However, you do have to take some. Just listening to the videos, just memorizing suffixes and prefixes, and just memorizing words and drugs and prescriptions and medications, it isn't going to work. Because a key component of passing this test is building your test-taking stamina. Stamina, right? We were just talking about Alexei and I were just talking about building crecir, your examen stamina. So just like a muscle, just like you want to build a muscle, you want to build that strength in your brain. And normally we're not taking a 2-hour test, right? I mean, normally we don't have to focus on one thing for 2 hours. I don't know about you, but when I read a book, man, I 4 or 5 pages and I'm like, out, right? And that's what happens, if we don't build our ability to focus. The MBLEx is an hour and 50 minutes. They tell you you've got 2 hours, but really by the time you fill in all the blanks, it's about an hour and 50 minutes for a 100 question test. And so just going into it, know that you have, when you take repeated practice exams, and they have them on at AMTA, at the American Massage Therapy Association. They have practice exams at the Associated Bodywork and Massage Professional, ABMP. If you Google practice exam, you can pay for practice exams. And so it is important to take some. And I say in my program, I say at least 3 practice exams. And usually it takes at least 3 until you pass. Just saying. Because the challenge of the test is the test taking stamina. And what happens when we don't have enough stamina is we speed through the questions. We start hurrying up. Boom, boom. and we don't fully read the questions. So we're going to have an opportunity to read some questions today, a little bit later. But let's jump in and start our course material. Today it's pathology. All right, here we go. Here's what we're going to be seeing today, what we're going to be covering today. We're going to be covering tendon disorders. We're going to be covering headaches, whiplash, sprains and strains. We're going to talk about carpal tunnel syndrome. And if we get all the way through, we're going to be talking about myofascial pain syndrome versus fibromyalgia. We're going to take a look at some postural deviations, and then we'll wrap up with osteoarthritis and rheumatoid arthritis. What are the differences? So let's get started. Good, we got a whole half an hour to cover this, about 25 minutes. So let's have some fun. All right, what are examples of tendon disorders? Achilles tendinitis, tennis elbow, golfer's elbow. And then we're also going to talk about the differences between tendinitis and tendinosis, because that can be a little bit tricky on the test. So let's first take a look at Achilles tendinitis. Where is it? Right, it's actually in the Achilles, right? Touch it on yourself, find it on your own body. Let's take a look here at this image. I like how we're getting through these. Good. Yes. The Achilles tendon is at the distal end of the soleus. And if distal is a new word for you, go ahead and review navigating the body. And actually, last week's class as well, we talked about distal versus proximal. So distal is away from the body, proximal is close. So yeah, it's closer. Proximal is closer. And so take a look at navigating the body if that's a new word for you. But let's go ahead and touch our Achilles tendon, right? Just above the heel. And you'll see here with my pointer, just above the heel. But what we want to be clear on is that the Achilles tendon is actually a part of the soleus. The gastroc gets in there, the big round heart-shaped muscle, the gastroc, gastrocnemius, that heart-shaped muscle, that gets in there. So there's the medial and lateral head of the gastroc. That gets in there, but it's not a lot of it. As we dig down, we see that the soleus, that is its major tendon. I believe we have another picture of it here. Yeah. So it's at the distal end. It's the reciprocal muscle. We need to look at the reciprocal muscle. So reciprocal muscles, that might have been something you covered in school or maybe not, but it's the front and the back. So the reciprocal muscles, like the bicep and the tricep. The bicep would be considered the front, the tricep the back. So the quadriceps and the hamstrings. So the thigh, the front of the thigh, and then the back of the thigh, that's the quadriceps and the hamstrings. Those are considered reciprocal muscles. And I want to introduce you to the reciprocal muscle of the Achilles tendon and the soleus. The reciprocal muscle is the posterior tibialis. Most likely you won't be tested on that, but I tell you because it's very effective in the relief of Achilles tendinitis to treat the reciprocal muscles. So we all go and we all work the calf, right? We all go and we all work the gastroc, and we do some cross fiber friction. We get some blood flow in there. Remember to work the front as well as the back. And if you touch your shin, your tibia, and you just tap on it, then just behind the tibia on the medial side, as it's shown here, is where you find your posterior tibialis. Those are the reciprocal muscles, and very effective again to work that. So this is Achilles tendinitis. Let's take a look at tennis elbow. Where do people feel it? Now here is a key part of understanding the difference between between tennis elbow and golfer's elbow. Now, to be honest, in the treatment room, we treat both, right? If we've got elbow pain, if someone has some elbow pain, we're going to treat both condyles, right? These are called epicondyles, bony landmarks, right, on the elbow, right? We're going to treat both. So even if they come in and say, oh, I have tennis elbow, treat both. But let's take a look specifically at where tennis elbow is. Tennis elbow is the lateral epicondyle. Now, the key to that is being in anatomical position. So let's take a look. If we're in anatomical position, I'm going to stand up here. That means that our arms are out by our side and our palms are facing forward, right? And so when my arm is in this position and it's facing forward, where is the lateral epicondyle? Is it here or is it here? Right? Here is actually medial because it's closer to the body. Lateral is out here. It's on the thumb side, right? And that's where tennis elbow occurs, is in the lateral epicondyle of the long bone of the arm, the humerus. So it's actually part of the humerus, and it's that thumb side. It's a chronic overuse injury as well. It's something that, because someone has hit the tennis ball over and over and over again, it's considered a chronic overuse injury. Its close neighbor is golfer's elbow, right? And usually we see it, sometimes golfers get tennis elbow. Sometimes tennis, players get golfer's elbow. That's why we treat both epicondyles when there's any elbow pain. But golfer's elbow is actually with the medial epicondyle. So another term for golfer's elbow is medial epicondylitis. So touch your medial. It says your medical epicondyle, but don't touch your medical epicondyle, touch your medial epicondyle. And when we go back to anatomical position, right? Arms out, palms forward. Our medial epicondyle is on our pinky side. So palms out, pinky side. So golfer's elbow is also known, like I said, as medial epicondylitis. Treatment is rest, unfortunately. Sometimes we can do some moderate cross-fiber friction on both of the epicondyles. But really what it is, it's an inflamed tendon, right? So that's what is the itis. Because remember, everything that ends with itis, Achilles tendinitis, lateral or medial epicondylitis, itis, I-T-I-S, means inflammation. All right. Now we've got tendinitis versus tendinosis. Now, why do we care? Well, we care because the treatment of each is very different. What do we know about tendinitis? What do we see here? I-T-I-S, right? So we know that this is an inflammation of the tendon. Let's take a look. Tendinitis is like pain, burning, wherever we have a tendon, and tendons attach muscles to bones. So there's decreased strength, there's, usually you can't perform whatever, well, it says daily activities, but activities of daily living. But if you're a golfer, you're a tennis player, you're a pickleball player, you're shooting basketballs, that tendinitis, maybe it's in, maybe you're a skier and you've got, tendinitis in your knees. Then you think of it's kind of pain, burning, but tendinosis, which is O-S-I-S, you treat it very differently. Let's take a look at how you treat the osis, because as licensed massage therapists, we want to differentiate, because you treat tendinitis one way and you treat tendinosis, it's a degeneration. If you look straight down here, it is chronic overuse like itis, but osis, tendinosis, it is a thickening of the collagen in that tendon. And so and this is something that can become chronic overuse. And in fact, one of the examples they use is even just clicking a mouse.
Mm-hmm.
And this is not inflammation. Tendinosis is not inflammation. It's a thickening of the tendons, collagen, and we have to rehab it completely different. It actually needs time to heal. So we distinguish between the two because the treatments are different. Tendinitis, you want to reduce the inflammation. And tendinosis, you want to break the cycle of injury because that tendon just keeps getting re-injured. And now it's thickening like scar tissue. And so that actually needs to either have physical therapy or have rest. Those are the differences between itis and osis. And one of the other things I want to just point out before we continue here is that read the questions carefully.
Mm-hmm.
When you read your MBLEx questions, read them carefully. It's very easy to confuse these two. We have to look at itis versus osis. This is inflammation all the time. This is a damage of the actual tendon. There's been a thickening of that tendon. And rest is usually what we need. All right, let's move on. So, one more slide on this. So another important consideration is that some treatments for tendinitis are contraindicated for osis, for tendinosis. So for example, ibuprofen, any of the NSAIDs, any of the NSAIDs treat tendinitis. But we don't want that for tendinosis because it's not going to fix the problem. And sometimes there's a steroid injection, sometimes orally if there's an osis. Again, just distinguishing the difference between those two. You can go back and take a look at these slides again if you want to read more in depth. Let's move on to headaches. What's the big deal? All right, well, let's just take a peek because there are different types of headaches, right? Let's take a look at where headaches come from. So we've got a primary headache and a secondary headache. So primary is you've caused it. Like it's not a symptom of anything else going on. It's not a secondary is a symptom of another underlying condition. So you've got a primary headache, you've just got a headache. It doesn't mean anything else. You kind of know how you caused it. Here's take a look. Primary headaches include migraines, tension headache. Tension headaches are muscle tension headaches that we think of traditional headaches. They're usually associated with trigger points. This is an abbreviation for trigger points. Sometimes you can get an exercise headache, right? If you run a marathon or you run in the heat, that's kind of blood pressure headache. So that's not a secondary concern. You did something, it caused a headache. You know, I didn't get enough sleep, I drank caffeine. Yeah. Now, taking a look at the secondary headaches. Oh, here are some other examples of primary headaches. Alcohol sometimes is involved if there's a hangover. Certain processed foods, lack of sleep. Sometimes if you have forward posture, if we get to it, we'll do some postural deviations, but driving a long distance and bringing that chin closer and closer to the steering wheel, that's poor posture and can cause a tension headache. Sometimes people who skip a meal get a headache, and of course, stress. These are secondary headaches. This is another condition is causing the headache. So let's take a look. A sinus infection, carbon monoxide, concussion, dehydration, some dental problems if there's a TMJ, structural dysfunction, And sometimes ear infections can also cause headaches. This is considered a secondary headache. It's a sign of something else is going on. All right, some other causes: high blood pressure, using too much pain medication, even just from, like, if you've got a helmet that's too tight, that can cause a headache. These are all possible causes of secondary headaches. Now, when someone gets a headache and they're like, oh my God, I have encephalitis, probably not. But maybe, probably not. Let's move on to whiplash, because we're going through these a little quickly, but I'd like to get through all of our conditions and then move into our questions. So hang in there with me. Thanks. All right. Why do we care? Why do we care about whiplash? Well, we care about whiplash because it's actually contraindicated to work on it. If there has been a whiplash diagnosis, it is contraindicated for 72 hours. So that means 3 days, unless they've been cleared by a doctor. So what is whiplash? Whiplash is a whip of the neck. And it's usually from an impact in the back. So let's think of a car accident, a rear end collision. And it forces the head forward and back like a whip. You know, a check, right? Big whip.
Mhm.
So the head goes forward because of the rear, the force from the rear. Say very common when there's been a car accident where it hits the back of the car, forward and then back. Rear auto accident, but sometimes it comes even from like a sports injury. Someone like in soccer, for example, they go up to kick a ball, they do a little windmill, they land on their back, and their head hits the ground. That actually can be a type of whiplash. You can think, I'm sure, of all sorts of other things, but a blow to the head is a contraindication for massage for 72 hours. Why do we say 72 hours? It is actually because of the endorphins that will be in the system. So when there is a car accident, when there is a sports injury, when there's a trauma, our body naturally releases endorphins and we don't feel it. Maybe you even know someone who says, oh my gosh, I was in a car accident earlier today, but I feel fine. I actually feel fine. I don't need to go to the doctor. I don't need to go to the hospital. They actually need to go because the endorphins in their system are masking their injuries. And often they'll wake up the next day and they've told the police they're fine, right? They've told the ambulance driver, I don't need to go. And they're like, oh my goodness, I'm so sore today. That's because the endorphins have been cleaned out of their body. And depending on a person's metabolism, that can take up to 72 hours. So that's why it's contraindicated to do massage with whiplash or with any blow to the head. Makes sense, right?
Yeah.
All right. Phew. If we were actually in class, we would not be going this fast. But I just know you've seen this stuff before. And so it's probably a review for you. And if it isn't, you can go back and listen again, or you can do the full pathology lesson in the online learning center. But let's move into sprains and strains. Okay, what's the difference? Let's take a look. A sprain is a stretching or tearing of ligaments. So a sprain is you've sprained a ligament. And you see in the image here, there's a little bit of black and blue. Ligaments attach bones to bones. What do you think's coming next? Yeah, strains. So a strain is a stretching or a tearing of a muscle or a tendon. So you can strain your muscle. You can strain a tendon. And oftentimes, again, there's a black and blue. And the tendon from the muscle belly, we have two tendons, right? Upper and lower, the origin and the insertion. That's where strains happen. They connect that muscle belly, nice muscle belly, to the bone. So that's a tendon. Ligaments, going back, attach bones to bones. Tendons attach muscles to bones. All right, carpal tunnel, we're getting through it. We're getting through it. I don't know if we're gonna get through myofascial pain syndrome, but we're gonna try. But let's talk about carpal tunnel syndrome. I love carpal tunnel syndrome. Well, I don't love the syndrome, but I love working on the carpal tunnel. It's so effective. Oh my goodness. And so the carpal tunnel is actually right here in our wrist. And they call it a tunnel because it's more like an arch. It's an arc of 9 bones that create this tunnel for the carpal nerve to go through. So it makes this arch, and the carpal nerve goes through the arch. The arch is a bone. It's almost like when you see those European bridges that are arched, bridges made of stone. Very similar to the carpal bridge that makes a tunnel. The nerves go through that tunnel. And the syndrome, carpal tunnel syndrome, is when that carpal tunnel gets too small. So there's a ligament, you'll see here in the image, there's a ligament on the palm side.
Compressed.
Exactly, when it gets compressed. So say from a lot of typing, it gets compressed and it shrinks. It shortens, it tightens. And it tightens almost like you're putting on a watch that's a little too tight. The effect turns out to be numbness and tingling in the hands. It can actually be in the hand and the arm. So it's a compression of that nerve. So you see here even a clearer picture of the carpal tunnel, the carpal ligament. It's happening right here. The median nerve, you see here. And see how those nerves go out to the fingers. Mm-hmm. And when that ligament gets too tight, then it compresses that tunnel. So when we treat carpal tunnel, if someone comes in with carpal tunnel and they're like, you can't do anything about it. What could we do?
Relax.
Exactly. We could relax. Well, of course, we can relax the muscles of the arms. We can warm up this carpal ligament.
Dilation.
Yes, balance it, warm it up, cross fiber friction on there. Get it nice and warm. And what ends up happening, it's just like loosening a watch. It opens up and the nerve is no longer compressed. And that way it's not zinging anymore. All right, but that's what carpal tunnel syndrome is. All right, moving along, take a breath, and exhale it out. This is also a great technique for when you're taking the test. Just take a breath and I let it out. Got about 5 more minutes of content, and then we're going to move into dissecting some questions. Okay. All right, this is a big word. Myofascial pain syndrome and fibromyalgia. Probably in the recesses of your mind, you're like, oh yeah, I remember that. Let's take a peek. Myofascial pain syndrome is random and all over the body. It's often grouped into certain areas, shoulder, neck, it tends to gravitate towards certain areas. But there's trigger points within the muscle. And often when it's diagnosed as myofascial pain syndrome, the fascia is a key component of the pain pattern. Now, in the chat, I know you can still get to the chat. Oh, can I get to the chat? I think maybe. Yes, I can. Okay. What is fascia? What is it? Where is it? What does it do? What is fascia? So fascia is a coating on the muscles. It's a clear, slippery coating that covers all the muscles and all the organs. And if you've ever bought a raw chicken and you've pulled back that skin and you see this white glistening stuff, that's fascia. And we have fascia throughout our entire body. It covers all of our muscles and lets them glide, slippery, soft, almost water-like. It lets those muscles glide against each other. It lets our organs glide against one another. But when there's overuse, injury, sometimes that slipperiness goes away. If we're dehydrated, think back to the chicken. You know, when you pull back the skin and you see the slippery stuff, sometimes you also see some white stuff that we call gristle, right? We don't want to eat the gristle. It's tough, it's chewy. That's what the fascia looks like when there's overuse. It's tough. It still moves a little bit, but it's not slippery and glidey. And so with that gristle, the beautiful thing about a human being is that wherever their fascia is stuck or turned into a little gristle, when we warm it up, it actually gets loose again. It gets clear. It restores back to its normal homeostasis, its normal state of being. And that's a bit about how we treat myofascial pain syndrome. But the difference between myofascial pain syndrome and fibromyalgia, so a little quick review, myofascial is usually lopsided. It has a main focal point, but with fibro, sometimes people confuse fibromyalgia with myofascial pain syndrome or with chronic fatigue syndrome. But we know that myofascial pain syndrome has to do with the muscles, it has to do with the fascia, it has a general area, but fibromyalgia is super specific. It actually has tender points that are trackable. So there are these 18 tender points in the body, or 9 sets of 2. So you see we've got the lower cervical region, we've got the second rib, greater trochanter. Let's look here, occiput. I think almost everybody has number 13 and 14. But these are elbows, the lateral epicondyles, and then the glutes. We also have just below the knee, the popliteal region. But there are sets of these. That's what's different between fibro and myofascial pain syndrome, is that fibro is diagnosed with these sets of tender points. And usually to be diagnosed, a person has at least 11 of the 18 tender points. So at least 5 sets, 6 sets of these tender points. So these tender points have also been present for at least 3 months. And usually they're of uncertain origin. So that just is a fancy way to say that the patient doesn't know why they're there.
And
It's closely related to stress. Sorry, do you have a question?
yeah, the you said about the fibromyalgia. What is caused by?
So that's a great question. People at the doctors are not sure what causes fibro. However, I will tell you my experience of fibromyalgia is there's a term called the biopsychosocial model. So bio, psycho, social, three parts of that word: the biology, the psychology, and the social situation. And there are volumes of books written about this, about the biopsychosocial factors that influence pain. And so it's not always the biology. Sometimes it's the mental stress.
Yeah.
Sometimes it's a social situation. And in the past, people would say, what's a social situation? Well, going home for the holidays.
And then we, as a massage therapist, can be treated by the digital pressure in that area, that point that you said that you showed us.
So as massage therapists, we are very blessed that we can treat fibromyalgia. It is one of the very few treatments that consistently helps. Because this is not just about the biology, right? I'm going to go back to our tender points here. So it's not just about the biology. Yes, it's trackable, but it's also about creating an environment where the client can relieve their stress.
Yeah.
And if we interrupt the pain cycle enough times, the body will heal.
Okay.
So fibro technically occurs on both sides of the body. It's very bilateral. And usually myofascial pain syndrome is concentrated in a certain cluster, a lot of times just on one side of the body or one area. All right. We'll go through quick postural deviations, but we're not going to get to arthritis. Here's the picture. These are this is the definition of postural deviations. So we say ideal posture, but there are ideal postures that are different for everybody.
Yeah.
This is called a sway back, where we've got a little bit, mostly it's a posterior tilt to the pelvis.
Mm-hmm.
So here we've got a military back. It's very flat. This is flat back. So look at the posture here with military back. See how that it is straight, but see how the chest comes out?
Mm-hmm.
So the chest comes out, but the pelvis drops forward. And you don't actually need to know the terms of these postural deviations, just the general category of postural deviations. Two words you will want to know is kyphotic and lordotic. So kyphotic refers to the thoracic spine,
Mm-hmm.
and lordotic refers to the lumbar spine. And here we see a forward head position, like we talked about, that may cause a headache.
Mm-hmm.
Ideal posture is different for everyone. And that's, so there's no perfect posture. It's what's good for that person. But these are common deviations. All right. Got to stop there. Sorry. We got to do some dissecting of the questions. Let's have some fun dissecting questions. And that's a lot of information. And that's not even all of the pathology conditions that we do need to understand. And we're not doctors. We're not nurses, right? We don't diagnose. We don't prescribe. The purpose of understanding pathology as a massage therapist is to know the session adaptations that we might need to make.
Mm-hmm.
And so how does it show up? How does that pathology, how do we treat it? But then what other session adaptations How do we adapt our massage to accommodate these pathologies? Let's take a look. All right. First question. A tension headache is defined as a blank. Now, I'm going to remind all of the people listening, including the students in class right now, of our test-taking strategy. Read the question again, eliminate 2 wrong answers, and then pick the best answer. So we're going to go through that strategy with these questions in the time that we have remaining today. All right, a tension headache is defined as a blank. A, muscle contraction headache with trigger points. B, rebound headache. C, grouping of headaches. D, neurological disorder. Can we eliminate any of these answers? A tension headache is defined as, well, go ahead and in the chat, if you're live right now, you can go here in the chat, your answer. So once you think you know the answer, you can put it in the chat box. But let's see, what's a rebound headache? I'm not even sure what that is. Did you get hit by a basketball trying to get a rebound? Maybe you're rebounding from drugs or rebounding from coming off of medication. Sound tension headache, it's a headache. Grouping of headaches, tension headache is not a grouping of headaches. Is a tension headache a neurological disorder? Maybe. But what is the best answer? Is a tension headache a muscle contraction headache with trigger points? The correct answer? Oh, go ahead. You got an answer? Alexei, what do you got? What do you got? What do you think? Dígame otra vez, por favor.
A, muscle contraction headache with trigger points.
That is correct. That is the correct answer. A tension headache is defined as a muscle contraction headache and sometimes has trigger points. Very good. Next. All right. Now, I know a lot of people watching are really concerned about medication and memorizing medications. And oh my goodness, there's 1,000 medications. You don't need to memorize them. Just watch this question. If a client's medication, RX stands for prescription, if a client's medication decreases pain, what must you do to ensure the client's safety during the treatment? A, make adjustments to your speech. B, wait 48 hours after medication before giving treatment. C, use deep muscle tissue techniques with caution. D, consult a physician before treatment. If a client's medication decreases pain, what must you do to ensure the client's safety during treatment? Let's eliminate at least one answer. Do you have to adjust your speech? Probably not. It doesn't say that the client is hard of hearing, right? And the client's medicine is probably not going to affect their hearing. It's decreasing their pain. Okay, so not letter A. All right. Wait 48 hours after medication before giving treatment. Use deep muscle tissue techniques with caution. Consult a physician before treatment.
No.
Probably don't need to consult a physician. Yeah, probably not. I mean, if there's another condition you're concerned about, but a lot of people are on pain relievers, or they're on a medication to decrease their pain relievers, pain medication. All right, so we're not going to talk to the doctor. So we got B or C. What you got? B or C? The correct answer is?
B.
It's actually C.
C.
Letter C like cat. The reason being, here's the funny thing. B, C, and D are all right. They're all correct. They're potentially correct answers. This is a beautiful example of a question that has distractions in the answer. And in the MBLEx, every single question will have distractors in the answer. They will look right, but it's not the best answer. So yeah, you could wait 48 hours, but what if they're on daily medication? What if they're on daily pain pills? They're never going to get a massage, right? So what we need to do is we use deep tissue massage techniques with caution. Why would we need to use caution? He's on medicine to reduce his pain. You know what else pain medicine does? It reduces our sensitivity. And so someone on pain meds may be telling us, oh, I don't really feel that, go deeper, go deeper. Well, they don't really feel it because they're on pain meds. So we have to use deep muscle techniques, deep muscle tissue techniques with caution. All right, we're going for it. We're going for it. Okay. Oh, here we go. Pain felt in the lateral epicondyle. The lateral epicondyle is a symptom of A, common flexor tendinosis, B, tennis elbow, C, golfer's elbow, D, radial epicondylitis. Ah, we just heard all these words. Oh my goodness. Okay.
B.
Hint, get into anatomical position. Whoop, remember anatomical position? Standing up. Feet are hip width apart. Arm out by your side. Palm facing forward. Where is our lateral epicondyle? Put your hand on your lateral epicondyle. Is it thumb side or pinky side?
Outside.
It's actually thumb side. Yes, thumb side. Right. Exactly. So we just learned that on the thumb side. So we know it's going to be tennis elbow or golfer's elbow, right? You just learned this. All right.
Tennis elbow.
Boom, it's tennis elbow. That is correct. Tennis elbow. Golfer's elbow is pinky side.
Yeah.
Tennis elbow is thumb side. Lateral epicondylitis. Good. Now, the tricky thing is, if you look at your arm, not in anatomical position, what's lateral, what's medial? Got to remember to go to anatomical position when we're getting these directions in our question. All right. Here's another crazy drug question, medication question. What is Atarax? What's it for? Yikes, I don't know. I didn't memorize drugs. You don't have to memorize. Watch. The medication, prescription, hydroxyzine embonate. The name is Atarax, is an antihistamine, sedative, and antispasmodic, typically used to treat which conditions? Holy crap. I don't know, but you do know. Watch. All right, let's get rid of a couple of the wrong answers. All right, so this medication we've never heard of is an antihistamine, a sedative, and an antispasmodic. Okay, that's what it's treating. All right, A, stress and allergies. B, rheumatoid arthritis. D, degenerative disc disease and fibro. Post-stroke cardiac event. Let's get rid of 2. So sedative, antispasmodic, antihistamine. Does that have anything to do with degenerative disc disease?
No.
Nope, sure doesn't. So we can get rid of C. Rheumatoid arthritis, itis, inflammation. antihistamine, sedative, antispasmodic.
Should be.
Now, it's not going to be arthritis, right? All right, that leaves A, stress and allergies, D, post-stroke cardiac event. All right, what's your best guess? A or D? Antihistamine. We use an antihistamine to treat allergies, don't we? Antispasmodic, that means antispasm. That might have to do with allergies. Post-stroke cardiac event, that's going to be like a blood thinner, right? Because somebody's had a stroke. All right, make your best guess out there. The correct answer is letter A. Yes, letter A. So stress, sedative, allergies, antihistamine, letter A. All right, we're going to go through one more. Oh, what's this? Cerebral palsy. Cerebral palsy.
And we go back to the other the
We
last question.
can. Yes.
Any question about when they talk about the antihistamine could be only if I answer put me stress and allergy could be the right question?
So
Because from the very beginning we start about the histamina.
antihistamine, yeah.
It's about how to prepare to get a test, for relax your mind, the brain, to get in stress your mind. That's why you said about the stress, and the
Yes.
question talks about the question talks about the Arax is an histamine sedative, sedative, right? Antispasmodics should be for only for stress.
So it could be, all of those could be for stress, yes. And what's testing your knowledge is antihistamine. That was our giveaway, because an antihistamine specifically treats allergies.
Yeah, there is nothing to do with any pathology, no pathologies.
No, I don't think antihistamine treats any other pathologies other than the allergy. Maybe, but I'm not aware of it.
Oh, okay.
Yeah. Yeah. In this case, the answer was A, because here's the other thing. Do we need a sedative for arthritis? Do we need a sedative? What's a sedative for? That's a distractor. That's like, what? Well, sedative for stress. Yeah. Do we need a sedative for a post-cardiac event? Maybe. But do we need an antispasmodic for post-stroke? So again, we're looking here. This is a great example of finding the best answer. Not always easy. And we normally can't do it by rushing.
Yeah.
Let's do one or two more questions. Let's do two more. Cerebral palsy. Okay, CP. A lot of times they get confused. CP, muscular dystrophy, muscular sclerosis, multiple sclerosis. What is it? All right, cerebral palsy is a motor function disorder that results from damage to the immature brain. Okay, that's what it is, and it's termed a blank. So we have to figure out, is it a systemic concern? B, is it a condition of the PNS? C, is it a sympathetic nervous system, nervous response? Or is it D, a condition of the CNS? Ooh, I remember getting these questions on the test and I'm like, what the heck is the PNS? What's the CNS? All right, what is PNS?
Peripheral nervous system.
Bang, yes. And what's the CNS?
Central nervous system.
The central nervous system, that's right, exactly. So let's go back to the question. Cerebral palsy is a motor function disorder that results from damage to the immature brain. So cerebral palsy, damage, brain. Is it a systemic concern? It's a weird answer. Is it a condition of the peripheral nervous system? Is it a sympathetic nervous system response? Is it a condition of the central nervous system? Cerebral palsy, disorder, damaged brain.
D. I call it D.
Are you saying letter what?
D. Condition of the CNS.
Bang. Exactly. Exactly. Letter D. D like dog. It is not a systemic concern. It is not a condition of the peripheral nervous system, right? The limbs and away from the brain and the spinal cord. It's not a condition of the nervous system. It's not a sympathetic nervous system response. It is a condition of D, the central nervous system. Good job. All right, last one. Let's not do another drug one. Oh, all right. Okay, this is a great one. This is a great one. All right. Which of the following pathologies is not a musculoskeletal injury? Oh, okay. Right. It says here what is not a musculoskeletal injury. Okay. Which of the following is not an injury? Okay. A, pes planus. B, sprains and strains. C, fracture. D, wounds and burns. All right, we got this in navigating the body. If you don't know the answer, you got to go back and do navigating the body, okay? Because this is a tricky one unless you know for sure, because there is one of these answers that is for sure not a musculoskeletal injury. We've got A, pes planus. B, sprains and strains. Okay, wait a minute. Are sprains and strains a musculoskeletal injury? Yes, it is.
Yes. Ligaments and tendons.
And what's are you giving an answer?
Yeah, I got the answer, but talking about the strains and sprains. It talks about the ligament and tendon.
Okay, put your answer in the chat because the echo in your mic is, I can't distinguish the letters, sorry. All right, I'm waiting for it to come up. Here we go. All right, so are you saying that it's the letter, did you already put it in there? Letter D, like dog?
Yes.
Okay, so wounds and burns, that would have been my answer too, you know? And then I looked up, what is pes planus? What is that?
Flat feet.
Remember that? I remembered it after I looked it up. I was like, damn it, pes planus is flat feet. The best answer is letter A, flat feet. That's not an injury. It's a condition. All right. Thanks for playing. Crazy, right?
What about D?
What about D? Oh, yeah. Actually, let me go back there for you. Hang on. Share my screen. Letter D was wounds and burns. And at first I was like, that is not a musculoskeletal injury, right? But the reaction, what happens with a wound or a burn, it actually damages the skin. It can damage the muscle. Bad burns, bad wounds can be a musculoskeletal injury. A bad wound can cut right through a muscle. So I know it's tricky.
Yeah.
And I share this with you because the MBLEx is tricky.
Because the pes planus is like a deformity, you know?
It's a deformity. It's not an injury.
Okay. That's
the best answer. I know. That's why I put
Right.
it in there, because it's tricky. Yeah. And so now, though, we start to get the rhythm of dissecting a question. We get the rhythm of getting rid of the wrong answers. We get in the rhythm of saying, okay, yeah, pes planus. That's right. So I tell you what, let me say a quick goodbye to everyone who's watching the video. Thank you so much. If you've tuned in to watch this video, I am Jody Scholes. I am your instructor for the MBLEx review course. You can reach me at jody@jodyscholes.com if you want to shoot me a note. Feel free to leave a comment. Go ahead and like the video. I really appreciate it. And thank you so much if you've already left a comment. They really do just light me up and continue to give me enthusiasm to continue to do these videos. So peace out for now, and we'll be in touch. Have a great day.